Hello everybody, this is Dr. Aldashan, a consultant gastroenterologist at MT. So today we have a 56 years old gentleman that referred from the oncologist for endoscopic ultrasound due to elevated CA19-9, more than 30,000 units. Patient has a lung mass that has been biopsied, and it seems that the origin of the histopathology, origin of the cells is pancreatic, hepatobiliary. So we're going to do today endoscopic ultrasound for this gentleman. What I usually do is I start with screening the liver. So I start with the hepatic vein, and then once you are in, you have to recognize the hepatic vein, screen the liver. That won't hurt. If you find anything abnormal, suspicious, it's good. If you don't, then it's also fine. And then you go a little bit, you push just a little bit to reach to the portal vein. Once you are in the porta hepatis, then you can start looking at the proper anatomy of the internal organs. Porta hepatis means next to it the CBD not dilated in this case, which means patient is not having an obstructive jaundice. The confluence is clearly here seen. The portal vein is dividing into the anatomical confluence. I don't see any pathological lymph nodes even in the portal vein area. Can I have please the flow? Yeah, that's very good. Please remove the flow, please. Remove the flow. No. So I always check for the portal, for the common hepatic duct and the portal vein at this point exactly. Flow, please. Where you can see that the portal vein, the common bile duct is very, very thin in this area. We go down a little bit, and when we start seeing noticing the head of the pancreas in this area. We can start. Don't freeze, please. Okay, thank you. You can see the head of pancreas in this area. The confluence coming a little bit congested. Yes, I can only say that. But I don't see any pathological lymph nodes in the porta hepatis here in this area. Once I direct my scope to the right a little bit, this is the hepatic artery I can see. Once I direct my port a little bit to the right, then I reach to the confluence region, and then the veins, each one takes its place. Pancreatic head is clear in this region. This is the confluence. This is the confluence dividing. This is the pancreatic head region, and this is the pancreatic duct here, as you can see. And then it goes to the pancreatic. You rotate to the right. You can follow the pancreatic duct always to keep the anatomy correct, and or the splenic vein. Keep them both in the middle. You follow until you reach to the kidney down, and or the spleen in this region, where you know that you have exited the pancreatic tail region. We don't see any abnormality in it, so basically we are going now to shift to the duodenal part. Then I move into D2. In D2 I have to make head up always, head up please. In D2 it's very important to pull slowly, so that we can see the pancreatic ampulla, as well as the pancreatic duct and the common bile duct in the D2, very close to the aorta in this region. So this is basically the pancreatic duct. Here is the pancreatic duct, starting at this point, where you can see this is the area of the pancreatic duct, starting point somewhere on this cross. Yes, this one, and it goes beyond that. We have seen it, of course, properly in the gastric position. Always head up. This is clearly where the pancreatic duct and the CBD meets at this point, and we can see that the ampulla is hypoechogenic in this area, a little bit different in the color in comparison with the pancreatic tissue. I still don't see any mass. I pull a little bit slowly, and I manipulate my device right and left. I can still see this is the ampulla here. Then I pull a little bit. I still don't see any pancreatic head mass. Pancreatic, this is the CBD, very thin, no abnormalities to be seen inside. When I go backwards, I still don't see any abnormalities in this region. I'm going out. I just pulled out, and that's it. So it's important to understand that elevated CA19-9, I don't like it, and I already see a zero consequence for it. Nevertheless, we have proven that we don't have any pancreatic lesions in this patient.